but I think the brightness is more, na? So
Yes,
here,
yes.
that's the cal
We are,
over
we
here,
are able
see?
to appreciate
Acha,
anyways.
okay.
Does it appear to be a hard stone?
I don't have the Hounsfield units on the CT, but definitely it appears to be a medium-ish stone, not a too hard or a too soft
Too
stone.
soft.
Nanjappa, how much do you believe in HU?
Yeah,
Many
I
times,
believe a lot
like
in HU
low
value, yes.
HU stones, you find out that you find on table that they are hard.
Yeah. There sometimes you get surprises, but HU value is detected by taking the value at almost 5 parts of your stone. It is not only in one part they take your value and give. So if you have a very good radiologist with you, definitely the HU value will be very important. So it tells you that if you want to take a larger volume of a stone with a very low HU value, then you may be able to do it off with RIRS very well. So it's always better that you have an HU value as a as a
Backup.
as one of the factors to decide whether you should go ahead with a case or no.
Nanjappa,
Yeah.
in today's age, Jackie here,
Huh?
so what is the role of lithotripsy now? Is it obsolete? Should
Hello?
we,
I can't hear you. Jackie, I can't hear.
is lithotripsy obsolete in these days of RIRS? Should I throw it in the Arabian Sea? What should I do?
No, I don't
What do
think
you do
so.
for your residual stones?
No, my residual stones also goes for RIRS only. Because we have a check RIRS at the time of stent removal or something. If you have residual stones, you go and back and do a flexible and you can get it out.
So what do you do with lithotripsy machine now?
So at present, I'm not using my lithotripsy machine, though I have a Direct with me in my center. I'm not using it for so many years now, but I would not definitely put it obsolete yet. With the electro, I mean, you can say the electromagnetic and the piezoelectric machines, which are very, very good in the previous generation. Only thing is, they are so expensive to use. I mean, if you want to buy a machine, for good machine, good quality, nothing less than 1 crore. Investing that on a lithotripsy today, only a person like you would be able to do it. But I mean, a smaller setup who doesn't have much of patience for lithotripsy, that would not be cost effective.
Nanjappa,
So, yeah.
the Lalisha here. Many times I have asked this particular question
Huh.
that if you are the patient, what would you do? Most of the doctors said we'll go for lithotripsy trial.
No, there at least you see your Hounsfield units, but
Of course, seeing that and small stone, 1 centimeter, maybe less than 1,000 and all that, suitable one. But in that also you are saying about RIRS.
Yeah.
But most of the doctors say that we would take a
And
trial of
it's a very
ESW.
valid thing. It's a very valid thing. I mean, in fact, when you ask the people sitting over here, 1 centimeter stone, HU of 800, 700, and Kandap or Rajappa is saying go ahead with RIRS. And if you are asked the question, what will you do?
Hello.
no, hello, you're asking me? Yeah, definitely. See,
I have something to say about this issue.
okay.
Because
Okay.
when we are telling the patients to go for ESW, there is a lot of things. Okay, what's the fragmentation rate, clearance rate, and when the patient is asking, it is difficult for him to accept that there are 20-30% residue stone fragmentation, 2-3 sittings. But as a doctor, we can easily accept that. So it is very difficult to get an informed consent for ESWL in our day-to-day patients. If the patient is ESWL is still good, but it takes a lot of time to explain the patient that these are the problems.
Now, our opinion in at least in Chhattisgarh is something very different. We have to contest for, we have to strongly fight for the PCNL and other modalities. People are readily agreeing for ESWL, even if it is 2, 3, 4 sittings. And yesterday we had discussed multiplied by 100 also.
See, Prashant, let us be very real.
Yeah.
How many people will do RIRS for a 4 mm fragment or for a 4 mm stone or 5 mm stone or 6 mm stone? Most of
I
us as
think in those
urologists-
cases,
most-
Jackie,
Huh.
the ideal procedure would be an RIRS.
So
Because
let me just
that if
finish.
you want
Ranjappa,
clearance
can-
in a very small stone, if you want
Any-
complete clearance, going in and getting
let
it
me just
out.
finish, Ranjappa. Clearly, when you see a patient with 4 mm stone, do you tell him I'm going to do RIRS? Do
You would
tell him
not
I'm going
treat
to do
you would not, first of
lithotripsy?
all-
You say that this is in the realm of the space where you can pass spontaneously. Then why you are worried about a 2 mm fragment not passing out, or 3 mm fragment passing out, or 4 mm fragment? So that's the way
I'll
you
be-
put it to the patient, and then you talk to the patient. If you have a renal pelvic calculus, upper calyceal calculus, mid calyceal calculus, 1 sitting, 2 sitting, maximum 2 sittings, you
I
will
have a
definitely
plastic
pass a
gown.
stone. Unless
I'm
you have 1500, 1600 HU unit.
मेरे को प्लास्टिक गाउन दो ना.
So, you know, you cannot say that all sizes
gown.
fit all. You have to personally decide the case, and you cannot say that I will do
Plastic
only
gown, plastic
RIRS
gown.
and I will not do an ESWL, or I will not do a conservative line of treatment.
ये प्लास्टिक गाउन किधर है? प्लास्टिक गाउन.
Is PCNL option in your setup? Huh.
If time permits, I think I will share one very interesting.
Yeah.
Can I?
Go ahead. Go
Thank you,
ahead.
Mike.
We still have time. I
So,
think.
3 years back, I was invited at Miami for a conference, Stone conference.
एकदम कम.
That time we had Dr. Manoj Monga and Dr. Olivier Trexler who were conducting the
0.5
debate.
बस, 5, 8,
The debate
0.5
was
बस.
1 centimeter stone, like what we are talking. RIRS, ESWL, PCN, mini PCN,
Mini PCN.
or observation. These were the four options given, and there were four eminent speakers who were talking about it. Then ultimately the result came down that at last people voted for two things. One is ESWL and second was RIRS. PCNL was out, observation was out. And then there was again a debate by these two speakers, and ultimately the RIRS person won. That time, and that
Dr. Chandramohan,
Yeah, let him complete.
yeah,
Let Kandar complete.
So
Yeah.
that time, when everybody clapped that RIRS won for 1 centimeter stone and the ESWL lost. And that is the time Dr. Manoj
you.
Monga asked Dr. Olivier Trexler that, okay, Olivier, I am going to throw one question,
Okay.
that if it is your stone, will you go for RIRS or you will go for lithotripsy?
exactly.
Right?
Yeah.
And they asked the same question to we were 70 people invited from all across the world for that particular conference.
ESWL
And
must have won.
everybody said that it is ESWL.
ESWL.
Of course, the Hounsfield value was 800, like what he
Yeah,
talked about, 800.
800,000.
Because abroad also it is very difficult to get very hard calcium oxalate monohydrate stone. There the stones are very soft.
Exactly the same
Right?
situation I had given you all.
So the point is that ESWL is not out. The problem is that it is out because of several reasons. One, the machine, choice of a machine. The machines are available for 10
There is a
lakh to 2 crore rupees price. Now, if you do not have a proper machine, proper technician, and urological intervention, because urologist they do not go for a lithotripsy. They just simply leave it to the technician.
Technicians will.
Right? So, because the financial dynamics also play into because you don't get anything when you go for so there are many factors for selecting a case for individual therapy. But certainly in my practice, if it is less than 1 centimeter size stone and HU is less, and if the patient is from Ahmedabad and a educated patient, I explain him for the lithotripsy first. But if the patient is coming from Rajasthan or some interior part, that time I do RIRS, because if with the ESWL, if he has to run to the some other medical help because of the fragments coming into the ureter and causing a problem, in that case, probably I think it is better to clear the stone at one go and do RIRS. But otherwise, if the patient is from my city, educated patient, less than 1 centimeter, less HU, I will certainly give him first option of a ESWL.
Even if he's from outside, out of Ahmedabad, why can't you simply stent and do a ESWL?
Man, you are
Follow up,
then
Follow up. Let him follow up.
Hey, that's fine.
Yeah. I
But
mean,
at least
I'm
the
asking.
personal
Just-
thing.
Yeah.
But it was a good discussion. I
Yeah,
think.
that's a
it was one
fantastic
of the
discussion.
pertinent thing.
Then I will explain everything.
So,
So now, Dr. Chandramohan, you would be.
the next case is going on. The
I
patient is
see.
ready. Yeah, we are back to you in the OT.
एक काम करो
Dr.
Dr. Sapnesh,
Hello,
sir.
जो है ना वो थोड़ा पीछे ले लो. Hello, can you hear me?
Hello.
Ravindra.
Can you hear me, sir? Prashant,
Huh,
sir?
yes.
Yeah.
Yes, Sapnesh.
Yes, sir. Sabri sir is just getting ready.
Okay.
Sir, 2 minutes time. Patient is already intubated and made prone.
Little loudly.
हाँ, late.
So it's a
हाँ स्किन है करे.
so she is a
थोड़ा नीचे ले लो.
46-year female
ठीक है.
No,
with the left
हाँ, ठीक है.
lower calyceal stone.
पोजीशन
Sir,
बराबर
within
है.
2 minutes, sir will speak.
Okay.
कहाँ गया? निडल कहाँ गया? निडल लाओ जरा.
Hello, Kamlesh. Dr. Kamlesh Maurya.
He's no proper.
Hello,
Yeah,
Dr.
yeah.
Kamlesh Maurya.
Yes, sir.
Yeah, you're not audible. Can you speak loudly, please?
Slightly bigger.
Yes, sir. I can hear you. Can you hear me, sir?
Yeah, can you have can you keep the mic a bit nearer to?
Yeah, yes, sir. Can you hear me now?
Yeah, better.
Sir, it is just a case of PCNL. Subnis sir is going to do. He's just checking the gadgets and getting comfortable with the new SIAM.
Reset karo.
It was just 2 minutes more.
Yeah, by that time, can you tell us about the patient and the
Reset karo, bhai.
Sir will
IVP?
be discussing about
No,
this
no,
very
reset
soon. He said he will just get adjusted and then talk to you.
Okay, fine.
This is being shown by Sabnis, no?
Yeah, this is
Dr.
Dr. Sabnis will be telling.
Sir, our both theaters are almost ready. One is Dr. Subnis who is doing a PCNL and other is Dr. Nanjappa who is doing an RIRS. Just we are waiting for the sir to be little comfortable
Alright.
with things.
Okay, so now
It's a left
we can start.
renal calculus.
We can start now.
Sir, I'm handing over the mic to Subnis sir.
Hello.
Hello, good afternoon, sir.
Okay, good afternoon. So this is a case for mini PCNL. You have seen the X-ray and you have seen the IVP. This is a lower calaceal stone and uretary catheter. You can focus on that. The lower calaceal stone. See that X-ray? Are you?
Can't see.
Can you
Well,
zoom in, please? Can you zoom in?
Now, now it's
Yeah.
Yeah.
Very
So
good.
that is a lower calaceal stone occupying the whole of lower calyx.
Right.
And there is not much dilatation. There are two small calyces which are seen, which are actually very small opening of the calyces and fusing into the infundibulum. Okay. So we have put a uretary catheter given a prone position. This patient is little obese, and there is hardly any gap between the ribs and the iliac crest. The bolsters are little different as to than the what actually we would have made, but nevertheless uretary catheter is put. Now we'll put a contrast. Focus on the X-ray. Focus on the fluoroscopy.
नाही म्हणाला तो.
Yeah, put contrast. So can you see that?
Yes, sir.
So that's a lower calyx which is occupying, and you see there is a small extension of the calyx which is quite lower down, and there is one calyx a little above.
Yes.
So here it really does not make any difference where exactly you go. Now the problem we are facing here is that this is the spine, this is the iliac crest, and this is the hardly any space. And if you see from here, normally we take entry like this, which is quite near the.
Can we have at the same time your Siam picture?
Can we have Siam picture?
Acha, you can't give both surface view and
Can't
Siam.
give both. Yeah.
Okay.
So I'm going to go like this. First, I will just mark it like this. You see on here that this is the way I will go. This
Why
is-
not inferior calyx?
No, because it is iliac crest is coming in the way.
Oh, I see. Acha. Okay.
Although this kidney is quite higher up on the IVP, but now with this position and with the bolster, the position has come in such a way that it is actually hitting the iliac bone. Iliac bone. You can see
Okay.
here. You can see here that this is the iliac bone which is coming. This is the ribs. So if I go in this direction, it is way higher. So I have to actually go like this. So this is the way I will go. But as you know, this calyx is just a small outpouch. You can see here that
Yes.
the whole, because of this stone blocking the infundibulum and the calyces, they are actually fused. So anytime, from anywhere you take the entry, it is not going to make any difference. So this is the mark I will make it.
Right.
This is the posterior axillary line. And in this direction, I will go.
So what is your criteria? When do you do, during expiration or inspiration?
Nothing like that. Nothing like
Nothing
that.
like that.
Nothing like that.
And in this particular case where there is a, you are finding it very difficult to enter because of the iliac small iliac bone,
Correct.
would you like to do it in expiration?
No, it does not make any difference.
It doesn't make a difference.
Usually, what we do in a obese patient like this, we put a towel clip and pull it so that we get little bit more space. Now, we have Dr. Prashant Mulaukar who is assisting here. We have a luxury that Mulaukar, such a senior person, is here to assist. I'm a little bit embarrassed that there is such a great assistant here. So now the other thing is we have studied this pelvic alyssal system. Important thing is to keep on injecting the saline. When we do fluoroscopy, as you know, that we need to mark, take a arbitrary position. Now this position is not going to be correct. How do you know it is correct or not? Is movement like this. This is a free movement which is happening. It is obviously not in the system. So you withdraw it little bit, go little, change the position, and try to puncture the kidney in a way. See whether it is not proper. So this position is not proper. So it has not punctured the kidney. So now what I will do is that if I am finding it difficult to understand where it is, whether to go anterior, posterior, we have to rotate. So rotate with 30 degree. थोड़ा saline inject कर लो towards me. थोड़ा ये डालो, contrast डालो.
You would make it 30 degree.
30 degree. Okay, so now I have to go much more anterior. All right. So this is grossly wrong. Go back 0 degree. Go back 0 degree. All right. So I withdraw it completely, not just little bit, but fully withdraw. Okay. So now this is the position. This is the movement of the kidney. This is the movement of the kidney. This may be a little bit nearby. I can again rotate 30 degree. So it is almost there. Make 0 degree. Make 0 degree. And
You have to go little in.
you may have to go a little bit adjustment. So we'll have to adjust a little bit. But now direct certain.
There is a question,
Yes.
Dr. Sabnis, whether air pyelogram would help.
So there are many people who put air and other things. We generally don't put anything. You put saline from below. There are many ways to find out the calyx. Some people put air, some people put 30 degree side by side, some people put 30 degree towards up and down.
And then there are some group of people who are totally against air pyelogram.
Air pyelogram, some people are happy, some people are having objections
To it.
there are some reports which have
Air
which have said
embolism.
that there is an incidence of air embolism.
Air embolism is there.
So there are some people who are against putting the any air.
True.
Inject saline, otherwise the fluid will not come unless you keep on injecting saline. We don't need any visualization of any calyx or anything. So there are many ways of puncturing the system. So as monoplanar, if you have very dilated system, if you have very clear thing, then you don't have to rotate. You just make by your judgment whether it is inside or outside, and make in and out. Otherwise, you make 30 degree and then see whether you want to go. Keep injecting saline. Keep injecting saline. So here it is almost that I have to target the stone and inject the and puncture it. Still it is not coming. So I will just withdraw it. I will withdraw and I will make adjustment little bit more.
You are going still anterior.
I'm going still anterior because it is little bit few millimeters anterior. Inject saline, inject saline. You're not getting saline. Mostly it is there somewhere. not filling the stone also. Such type of stone should be filled. 2 millimeters here and there. We can adjust, we can see the 30 degree again.
आमचं काय
Yeah, we have to still go little posterior. सीधा करो, सीधा करो, सीधा करो. Too deep.
Yeah.
So with little bit adjustments and this with 30 degree and you can puncture the system. Now here first thing is I'll put contrast. Just because you are getting water does not mean that everything is good. You have to see how you have gone into the system. Of course, in this case, it will not make much difference. So from here, from here, from here. In this case, it does not because we have seen that it is the compact calaceous stone and the calaces are not appropriate. So this puncture is perfectly okay.
Yes.
Yeah.
You
Yes.
see that? So now I'll put a wire.
But did you see a end on calyx, Sabnis?
No, because it was just there at the stone visualization, we made puncture there. That's it. This calyx is so small that it will not be seen. No, wire, wire.
No, if the die was pushed under pressure, probably you
No,
could
there
have
is
seen
no
that.
need. Actually, there is no need to, when there is such a small calyx, when there is a big dilated system, when calyces are fused, there is no need to see the end on calyx and things like that. It is not going to make any difference. Okay. So now here we have put a wire. This is a glide wire we use. Wire has gone into the ureter. So now what I will show you is the single step dilator. When you, where is that screw dilator? This is what we do, and this is actually what we do even in a conventional PCNL. If you see, can you see this dilator?
Do you
Yes.
always use screw dilator?
Always. In a mini PCNL or in conventional PCNL, because this is a tip which is 6
Sir.
French
Sabni sir,
and this is 14. Yes.
why the total inferior calyx is below the iliac crest, sir? Very surprising in
Yeah,
such cases.
that is also surprising. Yeah.
Entire inferior calyx is
I
below
know,
the iliac
I know,
crest.
I know. In fact, it was flush to the inferior calyx, which I am also a little bit surprised. So this is the tip which is 6 French and the shaft which is 14 French. So at one go, it will dilate from 6 to 14. This edge is conical, which is sharp, and therefore it goes and cuts the muscle and dilates it very well. If you see the, where is mini PCNL sheet? Torch sheet नहीं है? Torch का mini PCNL sheet लाओ, dilator. So that dilator is blunt. So that is not going to go as smoothly as the screw dilator will go. And once you dilate up to 14 French with the screw dilator, then passing the mini PCNL sheet becomes quite easy. Otherwise, if you just put a wire, puncture needle and wire, and then if you try to pass a mini PCNL sheet, then you will find a lot of difficulty. Now, important thing here is to maintain the direction. That's very important because our tract is not straight here because we had to go just above the iliac crest, avoiding the iliac crest. So when you are dilating, that has to be taken into account. And therefore, the method of dilating is not to use a force. See how I dilate and how we teach our resident is that you put one finger here and never force this way. It is not going to go forward with the forcing. It is just a rotation. Now you see, I'm not using any force. I'm not holding wire. I'm just rotating. I'm just rotating with the rotational force itself. The screw dilator or any dilator will go forward. There is no problem. Never force anything. It will automatically go. It will automatically go. That is enough. You don't have to force inside. Other thing very, very important is that somebody has to, इसका dilator लगेगा भाई. ये ऐसा नहीं जाता है. Somebody has to put the saline continuously into the pelvic calaceal system because with every puncture, with every dilatation, the clots are going to be formed. And especially when you are doing mini PCNL, if you are doing MIP excess, kaun sa hai sheet? 15, yeah. So now I will take out this, and then I will put a 15 French sheath. Stars, it has got its own dilator, it has got its own sheath. So you see this is a blunt end. This doesn't have any sharpness, and therefore, if you just put this sheath without this screw dilatation, then you will find it little difficult, and then you will have to force, and that will create a problem. Whereas now, because we have already dilated up to 14 French size, this dilator will go easily without much problem. We have this tract is a little zigzag, which is not as per the recommended thing. Zigzag tract is to be avoided. That is not a correct thing, but we had no option but to put a little zigzag tract here. We accept that. Okay, so this is enough. When the irrigation is going on continuously, the saline has to come from here. That is very, very important. All small clots, see, the biggest enemy of the mini perc or MIP excess, if you do continuously keep on injecting continuously, is the clot. Especially if you do MIP excess, which is a 8 French or a 11 French tract size, then this is a problem that sometimes clots will cause problem. Okay, here also, I'm not holding this, I'm not holding this. Only thing is that rotational movement. See, I'm going to support here and just rotational. You see the fluoroscopy, just rotational movement, that's it. Nothing, no force is required. I'm not holding here. Even I'm doing conventional, and if you are putting a rod and the implants, no need to hold the rod because that will cause problem. Here just a rotational movement, little bit time. No, you have to be little patient. Just rotational movement and it is going to go forward. There is no problem. Okay, so now it has reached. Inject saline, keep injecting saline. Unless you inject saline, the clots will be formed.
So this is, hello?
Yes. So now the saline is being injected. You see the fluid which is coming, and now we'll put a nephroscope. So you understand the method of dilatation,
Right.
and the method of this, no force is required. If you use force and if you hold the wire or the rod or something, then either you will do under dilatation or you will do excess dilatation, over dilatation. Both are not proper. With continuous irrigation of a saline from a ureteric catheter, all clots and other things which are formed, which are flimsy, will actually get washed out. If you don't do saline irrigation, then the clots gets organized. Clotting time is generally 3 to 4 to 10 minutes. So if you waste that time, now if this is the time which is wasted, then the clots gets organized, and then you have to spend time to remove the clots, because then stone gets obscured with the clot and all other things, then your time gets prolonged. So we do all this adjustment, white balance, putting the nephroscope, putting the light, everything ready. Moment you puncture dilate, straight away put a nephroscope and start doing the case. So that is very important. So what about 12 o'clock?
Hello?
Okay. So now we'll put a nephroscope inside saline. ये saline जाता क्यों नहीं है? Saline. This is a gravity irrigation. पानी चालू करो भाई. हाँ, जा रहा है, ठीक है. The gravity irrigation.
Yeah, can we have the endo view again?
Endo vision दे दो. See, these are some of the clots which are formed, and we know that these clots will actually cover the stone.
We don't have
Endo view is
vision.
not there.
Endo vision view दे दो भाई. Okay, so anyway, some clots are, we know that this is you see the stone here, that's a stone.
No, we are not able to see, sir.
They are adjusting the endovision view.
Okay. Is there?
Hello?
Yeah.
Can you see the stone?
Sabnis sir is free or?
No, Savni sir just about entering into the system.
So this is
And
a
once we
stone.
are inside that, then we'll come back to you.
This is a stone. This is the stone going from the infundibulum, and you see the stone here.
We are not able to see. Subnis,
Ah,
Dr.
endo-
Subnis, just now we can see.
So this is the stone, this is the wire. Our sheath is just at the calyx, and this is where we will start breaking the stone. Wire actually going from infundibulum.
And there is some plastic which is filled.
Plastic sheath that is
Plastic
coming.
sheet.
Sheath that is coming in between. Yeah, can you lower that down?
No, but you are getting endovision through indirectly.
Indirect vision mirror. Now, yeah, we are able to get it now.
So,
Yeah, that's fine.
So this is the stone. This is the whole lower calyx from
Again,
here.
it's gone.
We have lost it again.
आप यहाँ से ले लो ना. वो क्यों नहीं जा रहा है?
Yeah,
अभी
we are
आ-
able to see now.
Okay, so this is a stone. Okay, you can see the stone.
Sir.
This is stone lying in the infundibulum. This is the wire. Our wire has gone from here to the pelvis and to the ureter. If I go inside, there will be a opening of the ureter, and that's a uretary catheter. Okay,
Yes, sir.
so that is the infundibulum. This is the lower calyx, and that is the stone here. So we'll start breaking the stone here. All right.
What energy are you using, planning to use?
All right. All right.
Where's the laser?
I'm
machine?
using now here we have a thulium fiber.
Okay.
We have thulium fiber.
Dusting.
Fragmentation mode. We don't need dusting mode here.
0.8 will-
Here
0.5,
in
good.
PCNL, what is important
10
is
hertz मत
there is no
रखो,
need of
8 रखो
dusting.
ना
जरा
पहले,
नजदीक
देखेंगे
रहो.
स्टोन कितना हार्ड है फिर जाएंगे.
You don't need dusting. In PCNL, what is your objective is to fragment the stone, and fragments can be cleared from the, they will come out from the sheath. So
Yeah.
here we use 1.510. ये क्या है? 1.2 and 16. Yellow है कि blue है? कौन सा है? Yellow है? Okay. 1.5, 16. वो जो है बराबर है. Ready? Okay, so that will start breaking the stone. आने चालू रखो. Yeah, you can now, we just have to break, you just keep watching.
Yeah.
And we shift the camera to.
Yeah,
Dr.
we can
Nanjappa.
shift the camera to other OT. Dr.
We'll come
Nanjappa?
back to you.
Yeah.
Yeah.
So we have here, we have started the procedure of RIRS. So here, can you see the OT now? Are you all with me?
The surface view is there.
Surface view is there.
Surface view is there?
Yeah.
Okay, so access sheath is in. So just to tell you, the trolley is here. We are using a biorad.
No, can you
No,
focus?
can't see it properly. The camera.
Camera
needs to be
person.
adjusted. Yeah, now we can see what you're
Now you all can see?
Yeah. That's better.
Okay, so we have this endoscope from Biorad, which we are using over here. We have a 10-12 access sheath. The system is a bit inflamed, and that's why there is a bit of heme in the system. So this is this Biorad ka endoscope sleek, which is over there. This is a limited use scope, which they say will work for 30 hours. And this is a CMOS chip at the tip, which is over there, and it has 272-degree deflection on either side, quite lightweight. And with that, we are using a 10-12 access sheath, which is there in place. And for the irrigation, we are having a pathfinder here. So can you all see the endo view?
Yes.
Yeah.
Very clearly seen.
Can you all see that clear over there? See, there's a
Yes.
blood clot which has been slightly formed on the cal because the
Yes.
system is quite inflamed. So we calibrated the ureter and put in an access sheath, and slowly we will wait for some time. This cal is in the pelvis, looks a bit of a hardish cal, not a very, very soft cal. Okay.
Did you find any difficulty in putting the access sheet? Because you said that it only was 7 days before when the
Yeah,
DJ was
so
done.
actually there was no difficulty. A 10-12 access sheath went in, but definitely it was a slightly inflamed system. And now can you see that?
Yeah.
Can you see the cal over here?
Yes.
So as I keep the scope inside for some time, can you see that the whole vision is getting cleared slowly?
Yes.
Yeah, because there is this, the system was, slightly there was a heme over there, and it is still there, but it looks good. Now,
You will try to push it into calyx.
No, we are not going to push it into the calyx. I think the cal is quite big to go into any of the infundibulum over there, as you can see.
Yeah.
Okay. So what we are using with that is a 272 degree, 272 micron laser fiber.
प्रेशर दे दो तो ये सब स्टोन निकल जाएंगे
So we are using the
प्रेशर दे दो चलो
Quantas holmium laser 30 watt. The thing, I try to see that my scope is straight, so you can see that the, can you see the fluoro image over there? No, it will be difficult.
No.
इधर से प्रेशर आएगा ना पूरा
Nanjappa, can I ask you a question?
Yeah, sure.
Yeah. Ashish here. Do you adjust the position of the table like a tilt or a head low? If you feel
At
that the
present, we have
fragments-
not done that. At present, definitely that has to be done. You know, you give a bit of a head load for the patient is always better. And then you will start to see how the fragments can move so that they don't move into the lower calyx. And even tilting the table on to the side where you're operating would something be better so that, you know, you can have the upper calyx almost as the most dependent part of your,
would you like to raise the operative side or
No. Put it down rather than raise it. If you raise the this thing, head end, then the fragments would go into the lower calyx. So it will be
No.
difficult.
and how do you tilt the table which side?
Now tilting is not necessary unless it's when you are in the lower calyx and operating over there and you can't see the stone. Then you can tilt the table accordingly to get the stone in front of you, either in the side of surgery or towards the opposite side, depending on which side your working channel is. Now here, if you see that the working channel is at 11 o'clock, can you see that the working channel is at 11 o'clock?
Yes, yes.
Yeah, and so the laser fiber has been actually cleaved by Hiren. Hiren is assisting me here. And you can see we cleave the laser fiber, we don't strip it. And it is out for almost 1/4 of what the screen is. So it is adequately out at this stage. And that's how you have to place your laser fiber and fix it with the port seal over here. Can you all appreciate that?
Yes.
Okay. So now, this is the system, which we are using now has got an integrated monitor because the processor over there has, can you see we have two monitors here in the OR. Can you all see the surface view?
No, we are not able to see the surface view.
There are two monitors. One is an integrated system and the other is a slave monitor. On the monitor, what are things which are shown are how much time is left for your scope. Okay. So now he says that this is how much time it has been used. So now the thing has been changed by Biorad. I mean, a lot of things can be done by them just by software, changing their software. Now we go on to the laser. The laser machine is from Quanta. Can you see the settings over there on the laser machine? Can you show the laser screens?
Can you focus, please?
This is Qantas higher version.
No, 30 watt, 30 watt. So
30
you can
watts.
see the 272, 8 hertz is the frequency. The energy is 0.5 and it is dusting. Dusting means it's a long pulse mode.
Okay.
Long pulse mode. So once you are in the system, you can see axis sheath is right in. It's not too out or not too in. The curve of the scope. Can you show this? The curve of the scope has to be in this way. And can you see the position of me standing tilted onto the opposite side?
Yes.
So I'm operating
yes.
on the right side, so I'm just tilting it to the opposite side, though it becomes ergonomically friendly for me to do this. Can you all see this? Now we start lasing the stone. Yeah, ready? My plan would be first to dust the stone.
Sir, initially you said
Pilot
you are
light
using
off.
Pathfinder while introducing the scope. You are still using Pathfinder or just infusing?
No,
the
we are
light?
not using the Pathfinder at all now. Now it is by gravity. There are two ways of irrigation. One is by gravity and one is by pressure. So at present, what is going on is gravity. So gravity is around 40 centimeters. So that is That is 40 centimeters is the height by which the flow straight away goes on and you can have a good vision. Whenever you have the channel occupied by a larger diameter instrument or you have थोड़ा अपने को ये बढ़ाना पड़ेगा, फ्रीक्वेंसी बढ़ाना पड़ेगा, 15, very good.
Is this the usual Quanta or the Quanta Evo?
No,
Doctor-
not the Quanta Evo. This is the old generation of
Old generation.
Quanta.
Have you used the
So-
Quanta Evo?
I have not used the Quanta Evo, but the Quanta Evo has got so many features which are different than that of the
Old one. older
old one.
version.
It has got the vapor tunnel and it's got a dual fuse switch. Yeah, okay.
Dual switch.
So I have not used that yet. Ma'am, you're breathing. Hello. Ventilation. So it's very important that you see that the ventilation has to be maintained by the anesthetist. So we are using a painting technique. We are not very, very happy with the amount of dusting which is happening because definitely it's a hard stone, but doesn't matter. We can increase the energy also a bit now. So we go to point 8.
Nanjappa, we
Yes.
have a fiber coming out from 11 o'clock. How do you anticipate doing a left-sided lower calyceal calculus with this?
Anticipate doing
A left lower calyceal?
left side.
Yeah.
Yeah, that would be ideal for a left side. Na? This when it's coming at 11 o'clock, left side lower calyx is ideal.
And for the right side?
Right side will be difficult, lower calyx, because if it is a lower calyx which is posterior, then this fiber is going to come anterior when you're on the right side. So in the right side, you will have to just tilt your scope or turn it. So here on the right side, there will be a challenge for you, definitely. The thing to see whether how your scope matches your access sheath would be that there has to be a continuous flow of fluid which is coming on from the the mouth of the access sheath. So that should be a continuous drop which is coming over there. And I believe that is there coming over here. So you can focus that and show it that the match between the
Ranjappa,
marriage between.
Ranjappa, wait a minute. They have taken us to
No, we
the
are.
next OT. Dr. Sabnis.
Dr. Badwe, see, this case is over. I use this,
So I think
TFL
we'll shift over
energy.
to Nanjappa. Huh?
TFL energy is used. Now I will just show you
Yeah.
that this is our entry point. That's a infundibulum. That's a pelvis. And that is the ureteric catheter. Now you see, this is the few stones. And this is our entry point, this whole capacious lower calyx. One
Little
calyx.
loudly, Sabnis.
Capacious lower calyx. This is one calyx. You see that a small outpouching, almost fusing with the infundibulum. This was another outpouching fusing in the infundibulum, and this is our entry point. This is the lower calyx. This is the pelvis, and we are going down into
Quite a
the-
hard stone.
down in the pelvis here. One fragment of stone, we'll remove it, and no stent, no nephrostomy.
No, no,
No
frostomy.
stent?
So it's
Okay.
a tubeless and no stent.
Okay.
Okay, that's great.
So that ends the case. Everything is over, hardly any blood loss, and we have not taken much time.
Right.
Yeah, well done, well done.
Thank you. Thank you.
Thank you, sir. Thank you very much. Excellent demonstration. Yeah.
Now, Nanjappa, we are with you.
Yeah, so this is quite a hard stone. You all can see 0.8 and 15. So we are at 12 watts. Yesterday, the Quanta guys had told me that they have calibrated this machine because it's an old Holmium machine. I'm still the Holmium man. They have done it here, and almost 80% energy is being delivered by this machine, is what they mentioned.
Just press it for some time.
But what I plan is I'm planning only on dusting. So
Ureters to be kept for 1 day. Tomorrow, take it out. No, karo. I'm getting embarrassed here. Well, okay, he will do it.
Sir, one question.
Yeah, please go.
Sir, Nanjap sir,
Yes.
very nice demonstration. Sir, you wanted to keep the laser fiber at this junction, or you want to withdraw as your experience increases close to the scope? This is the ideal position we recommend.
See, you can, yeah, as you go on doing procedures, you can keep it very near the scope also and go, and it will become, it depends on your experience of how you do it. But if you take it too near, sometimes you can damage your scope.
Okay.
So you can keep it nearby also, and you can do according to your convenience. But for people who are to start their program, it's always better to keep it slightly away.
What
So that
about
would
the
be,
what about the holmium laser calibration you are mentioning?
Huh.
Do you think I also use Quanta? It is very good. Do you think these for the blast sheets and every 1 year we have to do some servicing? Is it correct or?
you're right on
Yeah.
that, because there are a lot of movable parts in a holmium laser.
Yes, sir. Yes, sir.
There are a lot of movable. It's like a normal car which you have now
Yes, sir.
and the electric car. There's a lot of difference,
Yes, sir.
So definitely there is going to be a challenge in the power delivery and all that, because the blast shield, alignments of prism, moving it from one OT to the other OT, all this is going to affect your delivery. So definitely as you go ahead, there are a lot of challenges for the holmium.
Yeah, holmium. Maintenance is
So
little.
maintenance is also there. Everything is going to be
Theater
there.
staff also should proper care for blast sheet, na sir?
Yes. I agree. And that would be one thing which is not there in your thulium
Thulium fiber.
is, and definitely so that is the advantage of a thulium. So
But dusting very nicely it happening with
I
holmium
would
laser.
still, I'm not Chandramohan, I'm still not very happy with the dusting, because the
Yeah.
time taken for the dusting is,
थोड़ा और फास्ट हो सकता है,
हाँ, बराबर बोला आपने.
थोड़ा स्लो हो रहा है.
Yeah, you can do that. If
Probably
yeah.
new
why
mission
why
will
can't
do.
we can, yeah, the new machine
New
would be,
machine will do
yes,
faster.
yes. This is like I'm slightly being slow. Sabnis sir has come here. Sabnis sir is asking me to demonstrate the thulium also with this same time. So I think we should, same stone, we should take a thulium. If we have the thulium, can we have the thulium? Yeah. And can we get it ready?
That's a
For
good
the
idea.
same stone, same time, and we can have the same thing.
Yes. And just I would like to have opinion from
Sabnis
you.
sir, though I was in this OR, I saw your demo. It was very beautiful.
Chandramohan, I mean, this as far as dusting is concerned, probably how
Hello?
would you rate thulium better than holmium as far as dusting is concerned?
More or less same sir. थोड़ा now I am used for thulium, but I enjoyed for 10 years with holmium. To be honest, new holmium versus thulium fiber same
Okay.
dusting. Best advantage is popcorning. Last May now he is doing na sir. Last May they will form some fragments na sir.
Fragments.
At any cost. कितना भी अच्छा करो.
थोड़ा ये power बढ़ा दो, 1 करो, इसको 1.
Very fast with thulium.
Okay.
Unimaginable fast.
Let us see.
100 times faster
Acha,
than.
okay.
That's where,
Chalega.
honestly. Otherwise, this dusting, you cannot identify when the laser fiber is changed.
Okay.
For example, without telling laser fiber is changed, you are doing with holmium and thulium. You cannot identify in the video when it is changed.
Okay.
Can you all see the dust here?
Yeah.
Golden
Yeah,
dust.
this is the actual dust, but only thing is, see, the hardness is quite a bit. Machine is not. मेरा mic बंद कर दिया है. हाँ.
Nanjappa,
Yeah.
now thulium and holmium,
Yeah.
the inner portion is going to be much harder. So
Huh?
obviously thulium will work better.
No. It is nothing like thulium works better, or that thulium is good for dusting. So definitely thulium would be a machine for RIRS. For RIRS, where you require everything to go on dusting. So thulium is the machine, but holmium will still remain, because holmium has very beautiful, fragmentation properties, and the power of the machine, because peak power is quite good. So in certain cases, you would like to use holmium. Actually, if you see in mini perks and those cases, sometimes a holmium would be a better choice rather than doing a thulium.
I think inherently thulium has more dusting capacity.
Do you all want
So
to
if
change
you have
from,
fragment, if you have to fragment using a thulium, it's really difficult.
It is very difficult.
And if you want to
Fragmentation with a thulium is very, very difficult.
Yes, and if you want to dust with holmium, it is relatively difficult. Hence, they have come up with this long length. But basically, I think is the property of the wavelength that defines whether it's going to dust or pulverize. So I think each
One
laser has its own advantages, and both are equally good. Now, even
Yeah.
the newer holmiums come with a rigid lens system,
Okay.
so you can just transport it and you can place it and you start working with it. So this lens and prism thing has slowly little. It's not very difficult nowadays. The transportable holmiums have also come up.
One
Chalo.
important point
We
I
are
want
going to
share.
change over from
If you
a
want to do very
holmium
fast, yes sir,
to a
yes sir.
thulium.
Yeah.
If you
There
want
is a,
to
So,
do it faster,
there is a comment from Dr.
That's
Chandramohan.
that's the dust with holmium.
yeah.
Nanjapa,
Okay.
yes.
Sir,
Hi.
if you wanted to do this stone in RIR is very fast. Manlo, you have given all the missions, all the best surgeons. You wanted to do fast because it will take time.
Yes.
1 hour it will take time. If somebody wants to do it in 15 minutes, you can do it with thulium fiber laser. You don't do dust, but it should be in the calyx. You make wantedly chips, wantedly. They will become around 20-30 chips. Then go to
Point
popcorn. It will
two.
finish in 5 minutes.
Yeah.
That is the major change in large volume stone. But concern
That
is
is
the
which
heat.
mode?
So if you are in the calyx, if the water outflow is good,
Okay. Which is
then
your
this
this
type
thing
of
yellow.
dust need not be done from
14
beginning.
to 0.4.
That
Yeah.
changes the entire scenario.
What is your opinion about
Pulse
using
width
it
is you
in
have
the
kept it
ureter?
as medium.
Middle ureter, lower ureter.
Dangerous if you do use high energy, high frequency, no dusting. Fragment and take out each pace like pneumatic lithotriptylum. No question of playing nicely there and spending large time. No way. Everybody accepts that, seniors like Oliver Traxler sir says that come out fast, don't use the energy more in around the ureter.
No, don't. Let's not go to.
In URA, especially if it's an impacted stone and you're using thulium, then you will have a lot of dust. It will cover the mucosa. It will become
No.
difficult to
Touching is
differentiate
having
between the
sparking.
stone and the ureter. It
No,
becomes
it will
difficult.
break. It will break.
And also
It is going. Don't worry.
it forms
Thulium fiber.
bigger bubbles, and which are dusty bubbles. So sometimes vision also gets impaired.
See, now we have started using the thulium machine.
Thulium machine.
So can you all have you all noticed? Did I take out the fiber and change the fiber?
No, you have not.
I
You are
have not.
using the
So
same
that's
fiber.
the thing of Quanta. Quanta doesn't require you to change the fiber. You can just change your machine. Now, this thulium fiber laser, I think already you all know about the thing. We are using a 0.4 and 40. We were at 12 watts. Now we are at 16 watts. Can you see the speed has increased?
Yeah.
Now everybody wants me to touch the stone. Because see, in thulium, what happens is the bubble is very small. So you have to go very near to the stone to work. But if you touch the stone, there'll be sparkling. So try and keep a small distance from the stone and go for the. So can you all see the dusting happening inside?
Yes, we are able to see.
Yes, Nanjappa, coming to the fibers,
Yeah.
basically all the fibers of all the machine come from one parent company.
Perfect.
So all the adapters that go into the machine are the same.
Excellent.
And each company
That
will
is
just
that
put in
is
a
what
chip.
that is what I wanted to tell everybody, that all the machine, the fibers are the same. There is no difference. It is only that the company does it so that there is
Yes.
some
Signature to
yes,
the fiber.
signature. So you don't have to worry. So all the fibers are the same. Nothing changes. And can you all see the dusting happening? There I've touched the mucosa. The white patch on the mucosa is over there.
Yeah. A bit of blanching has happened.
See, can you see the sparking which happened?
Yes.
But Nanjappa, this even happens with holmium.
See,
If you are-
holmium,
if you are-
it even happens in holmium. Only thing you
Yes.
can't see it. Why, the frequency in holmium is very less.
Correct.
So that is the reason why, see, there are slight amount of fragments coming out. I'll not be happy with that.
Slowly, the fineness of the dust is decreased. Chipping is
You can
happening.
decrease the energy.
If you decrease only, you can
0.4.
make like powder like. Now you show the powders, the difference between the
Yes.
thulium powder and holmium powder. It will be slightly, occasionally you will see chips.
See, now here, see the powder.
See, occasionally some
Now-
amount of chips may be seen, whereas in holmium it is slow, but very fine powder will form. So ultimately, if you want to make dust, face powder, you have to spend lot of time. You want to make
Basically,
fragment.
you have to be patient.
You have to be
basically.
patient. So this procedure is definitely takes a little bit of time. So
This is a hard stone, no
it's a
doubt
very
about
hard
it.
stone.
It is a
Very hard
very
stone.
hard stone. You know,
And
it
large
is,
volume also, sir.
yes,
See,
volume is also quite a big.
2 into 2
So
into
that's
2.
why it's quite a bit of a volume.
You are exceptionally painting nicely. Very good. Live transmission is exceptionally good, I am telling you. The Biorad
Thank you,
scope,
Chandraman.
Biorad scope and your movements are on the screen. It is the main screen. High definition transmission is happening here. Very high
Thank
definition.
you for that. So here I'm trying and avoiding to touch the stone.
Hello.
Yeah, yeah.
And Anjapa, just wanted again to go back to the ureter.
Yeah.
The fear is when we are talking about thulium that there is higher generation of heat.
Yeah.
And the fear in the ureter, as rightly Ashish and Chandra said, was that you don't want to do too much of laser in the ureter. What is your comment?
Yeah, definitely. See, don't say that thulium has higher incidence of heat generation. That is wrong. See, we are not comparing the settings exactly. What we are doing is we are comparing a 10 to a 15 hertz frequency of a holmium to a 40 or a 100 hertz frequency of a thulium. So you should not do that. You should try and see that you have the same settings on either of the machine, and then the heat generation definitely will be. See, now you see me only now. When I was operating on the holmium, my frequency was 15, and I'm operating on the thulium, my frequency is 40. So I myself have increased the frequency, and how many times with the holmium did I touch the mucosa?
Hardly ever.
Nah, but in the thulium, how many times did I touch the mucosa?
Almost 5 times.
Yes. So it is there where you are going to make the mistake because you are driving the car at a very high speed. Now, when we are driving the car at a high speed and you are not sure of your road, you are going to touch the divider once. So be careful when you don't have. So isliye it's always better that don't compare vis-a-vis. Go to the same settings, nothing will happen. So that's why in thulium, in the ureter, go to a very low frequency. Don't do masti. You have to have lot of patience, and that could be the key of how you can go about achieving and not touching the mucosa. Here I'm being very bindas because I'm in the pelvic calcium system PCS, so I don't have to worry how many times I touch the mucosa. But if I'm in the ureter, definitely this would be highly unacceptable.
Like Dr. Khadki says,
Yeah.
Pneumatic lithotripsy.
Uh,
In the ureter, would you still use pneumatic or those days are gone for you?
Yeah, there are very certain indications where you can use pneumatic. Still, I keep my pneumatic because if a stone is very badly impacted, covered with a mucosa completely, and you can't see the stone, you can just feel the stone. There are certain indications where, at that time you feel that, oh God, like, can I get some amount of space? And at that time, maybe I'll just use, but very rare, very rare. Because laser should always be fired when you can see the cal. If you don't see the stone, you should not fire the laser.
But for the juniors, you have to take into consideration that pneumatic lithotripter is the choice in impacted stone, especially if you are doing under spinal anesthesia in periphery. Please do not use laser high energy and keep on touching the mucosa. It will form stricture. It will form stricture, make into pieces, push back into kidney and do RIRS safe. In situ, break into pieces and remove is recommended by worldwide. How you break, if you want to break with laser, it should be in the center of the stone. That means your precision should be very good. That experienced persons will do. Otherwise, deep inspiration, suddenly laser touches one mucosa. Deep expiration, one mucosa. If you touch 5 times like that all around, you will finish. But these dots, he said, it is an highly unacceptable, the word. The same burning, if it happens in the ureter, it will form stricture. And that is equal to upper ureter if it happens. It's very, very disaster. Pushback or antigrade PCNL are safe for beginners. Ureter will not get damaged.
Or use pneumatic.
That's a nice take-home message.
But if we are using,
Yeah, definitely, I agree with Chandramohan on that point that ureter, you have to be very careful because all these series now will be having of ureteric stricture of people who have used it in the first 2 years of their practice. But now people have become very smart and they have changed the way of how they are using thulium fiber or lasers. So, definitely that has a very good. I think we have to give a slight, notice to our anesthetist also today. She has been maintaining the tidal volume quite well. So, this part, we have to tell that she has done a very good job by keeping the stone quite static and not moving it. Otherwise, that would be a very big deterrent on our finishing the case. Still, we have a long way to go.
Just a point to add for impacted
Yes.
ureteric stones. Whenever there's impaction and some mucosal edema, whenever we have to use a laser, I think using it at 0.5 joules or 500 millijoules should be a good choice. So low energy. And the mucosal, actually this blanches or burns the mucosa. I do not think when we are using laser, we are actually damaging the muscular layer of the ureter. Also, we are not damaging a complete circumference of the ureter. So, whether the ureteroscope is the cause of the stricture or whether the laser is the cause of the stricture maybe needs to be defined. And once we start burning the mucosa, we don't keep on burning the mucosa. One would always be a little cautious while using it. I think the take-home message should be low energy, cautious use of laser if you don't have a pneumatic in place.
I want to share my personal experience. That's why I'm pessimistic. Large stone pneumatic lithotripter junior was doing. Recently, at that time, 3 years back, we have taken TFL. I have gone inside and ureteroscopy is uniflow,
Ma'am,
not biflow. Access sheath will not be there. So temperature of the thing can happen. And I have done for 1 hour. Pan-ureteral stricture has formed. Worst complication I have seen. Total ureter necrosed. So don't underestimate once it happen in impacted stone. At least be careful because mucosa will be all surrounded by stone. Why not pneumatic lithotripter to bake into pieces? After that you laser when the stone is moving in the dilated ureter, not at the serious impaction. What is the advantage of laser in serious impaction to use the laser? Pneumatic lithotripter is cheaper. 0.8 probe will come. We are all used to 6 by 7.5 ureteroscopy. Even if you perforate with pneumatic, nothing will happen one area because it's anti-retrograde perforation. Water will not go back. So immediately you will get some space, push it up. After that you play with laser, no problem. I feel everybody should give, because this is important part of it. See, unknowingly or knowingly, many places the mucosa is touched. Even in my case, when I have done reasonably good way, all the mucosa are little blanched. That means if you go close, it will blanch.
yeah, I agree with that. That we have to be, I think lot of, see, slightly we are getting one fragment out here.
Yes, sir.
That is not a very good sign.
Invariably it will happen, sir.
Yes.
You tried
So,
very good up to now.
yeah. Now, once the volume of the stone becomes less, I agree, Chandramohan, that we have to keep on reducing our settings.
Yes.
Because now the stone will start to wobble, and now we are going to have challenges of maintaining this last part. Though you can see a few fragments, you compare it with our laser fiber, they are very small. In a digital scope, they appear to be quite magnified.
Yes, sir. Yes, sir.
So, that is the problem which you get. So don't get too disheartened by slight
No,
fragments.
sir, you are doing most ideal possible way. Only thing is that very big fragment नहीं बनना चाहिए.
Yeah, वही अभी कोशिश करने का. But every case is different and every stone.
Very big fragment if you make.
Yeah,
you have to
then
chase,
there is
you
a
have to chase
problem.
two stones you have to chase.
Then there is a problem. So
But
now,
very nicely it is coming, sir. So far you reduce the volume, you reduce
yes.
the surface area also.
So here Hiren is there with me and he said, sir, उसको उल्टा करके पीछे से भी करो.
Yeah. Oh, that's a very good suggestion.
Please don't take it literally.
No, it's very good important because fresh surface
Yes.
break नहीं होता है, powder होता है.
नंजोपा क्यों नहीं उल्टा करने का?
नहीं वो
Actually, I always
करण जौहर का पार्टी
do
अब भी
उल्टा.
हुआ है सर.
हाँ? कुछ आगे से कुछ पीछे से.
This is being recorded, so I can't be, I can't be my normal self when it's being recorded. So, yeah. That's right. What I agree with that. But Jackie, I take your point.
उल्टा करके भी सेम इफेक्ट आएगा ना
Nanjappa, why are you not doing it?
हाँ.
Why do you not want to
At
do it?
present, I'm comfortable. So, अभी देखो, अभी ये बड़ा fragment आ गया, देखो यहाँ.
हाँ.
ये आ गया, ये अच्छा नहीं है, ये अच्छा
So
नहीं है.
if the dilated system is there, it is अच्छा नहीं है.
हाँ, ये अच्छा नहीं है, ये अच्छा नहीं है. ये पहले क्या लिख, अभी छोटा कम कर दो, 0.2, 0.1 करो.
उल्टा करो, उल्टा करो.
हाँ, नहीं नहीं, वो 50
इतना
इतना
easy
नहीं, हाँ,
नहीं हो
0.1
पाएगा सर ये,
और
क्योंकि
40, वेरी गुड. चलो.
फ्लैट चुपका हुआ है वो. Is on the- You reduce the, he said energy reduce, but this is all very important for juniors, those who want to start RIRS. If you reduce the energy, it won't break into pieces. But another 4-5 minutes ज़्यादा time लगेगा, but you, under vision you finish the case very well. Satisfaction rate is very high. If you make fragments, somehow 1 or 2 fragments रह जाएगा, then the patients at ultrasound reports will show that. They will be very unhappy.
The RIRS now you have to keep talking,
patient
otherwise it
cannot
is very boring a surgery.
Yes, sir, that's
So
why I am
please,
talking. Really
that's why somebody has to talk. So we all have to talk. Now you have to keep discussing or something or the other. See, now we have come to the.
नहीं बहुत अच्छा अभी तक आया है. लास्ट 1/2 सेंटीमीटर हो
Nanjappa,
गया.
कम से कम we are not talking about stocks here. वो यूरो फाइनेंस नहीं है अभी तक. नहीं तो वो भी इंटरेस्टिंग टॉपिक है टाइप.
नहीं नहीं नहीं, वो सबनी सर को बोलेगा तो सर सर
चालू हो
कैन
जाएगा.
टॉक कंटिन्यूअसली.
Here the amount of the blanching is so minimal in this thing. In PCRL you make one hole itself, but here it is only superficial blanching. They say 0.15 mm is the depth of penetration. So they all will heal. We have seen after 2 months if you go inside, a nice mucosa will be there. So consequences may not be.
Now, madam, your respiration, thoda.
नहीं, continuing
Our
to that,
anesthetist
Dr. Chandra
movements
Mohan,
are
you said the depth
slightly
of
increased.
penetration is less. That is what Dr. Ashish was saying.
Yes, sir. Yes, sir.
So there is a bit
वो
of
अच्छा तो बोलो ना, मैं रुक
contradictory
जाता हूँ.
statement.
Yes.
मैं होल्ड
The
करूँ?
reason why I am telling.
हाँ चलेगा,
if it
प्लीज आप कर लो,
happens
आप कर लो,
repeatedly,
आप कर लो. I'm just giving it a break because our anesthetist want a break because
Sure.
she's carbon dioxide has gone up and she's not so happy. So let us give it. She wants a good ventilation here.
Okay.
We don't have a workstation, but we have a. Oh please, 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 madam, आप first you have to
Usually-
be comfortable. Then we are comfortable. आप कभी भी बोल दो रोक देंगे.
What our anesthetist does, Nanjappa, is
हाँ.
they use Venturi and give apnea, and that
Yeah,
can
yeah,
go
yeah, yeah,
that
yeah,
can
yeah.
go on for a
See,
long time
I would
without
definitely.
ETCO2 going up.
Yes. See, this is definitely a teamwork. RIRS is a teamwork. I definitely agree in centers where high volume RIRS is done. Everybody knows how to do their own stuff. Though I'm so impressed by the anesthesia given here, though I believe that the volume was not so high of the cases, but still it's quite good. But
Sir,
first thing is,
show the powder, sir.
yeah, I can show you the powder. See here. See, this is the powder.
Yeah, very good, excellent.
This is the powder.
Nanjappa,
Ah.
yeah, Nanjappa, since we're talking,
Yes.
can we inspect the other calyces and tell me what you do with the renal plaques which you see?
Yeah, well, we'll do that. She's still ready now because I'll just finish off the case and then we'll do it in the end. Because let us first get the patient comfortable.
Okay, sir.
Yeah. Yes.
What about renal?
Yeah, that is what everybody says. See, this one. This one.
Yes.
That is what Hiren suggests. Kandarp is here. Kandarp is in my OR now.
Excellent. This makes the edge, जैसा आशीष सर बोल रहा है, edge दिख जाएगा. Edge is useful so that stone doesn't break into pieces. Fantastic.
And it goes away from the mucosa.
Yes. This is an excellent demonstration of all points. And this is easily reproducible for the all RIRS junior surgeons. After 1 year, 2 years, everybody is doing this type of
Same technique.
I mean, same may not be this precisely, but possible. Learning curve is not that difficult.
मान लिया ACDC.
What is ACDC? अच्छा, BC. Jackie.
And he has kept in a calyx. It has gone into calyx end on, so it cannot go anywhere now.
And yeah.
That is also advantage. So everything experience is reflecting clearly. Same thing if you do in pelvis, we cannot do, sir.
Yes,
It moves.
it moves.
So somehow you have to push into one calyx.
But this went automatically.
Automatic.
Automatic.
जाता है, sir. जाता है. Water flow की वजह से it goes. That is true.
So Nanjappa, if
Yeah.
we go back to our debate, holmium versus thulium,
Yeah.
I think with the high energy which you are using in thulium, fragmentation was definitely faster. What do you think?
Fragmentation, dusting.
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 See,
Dusting
that's
was
the
much
that's
better.
the thing. Thulium is a very powerful machine. You can holmium also. There are high-end holmium. We are comparing a very low-end holmium to a high-end thulium.
Yes, sir.
Still, I would not, go on that debate straight away. There is lot of time still for everything to be settled down. So, see, when I'm going near the mucosa there, I'm hitting the mucosa, which I'm not very happy of.
See, sir, Ashish, sir, you see here, as the precision of a small stone is there, he will touch the mucosa more number of times now.
Yeah.
It is not like previous large surface area. Here, playing is very precise here. With one, see, every time respiration comes, you somehow touch. You observe after some more time, it will touch the mucosa more.
Madam, you are
That
comfortable now?
happens in the ureter. You don't have space.
Patient, very
You
important.
don't have space with rigid
Rest,
scope.
everything
At least
is
this is
okay.
flexible. Rigid scope is just end-on vision. You can't see anything. So with small respiration also, especially spinal, it is very, very dangerous. One more thing, sir, after doing this meticulously also, you see after 2 weeks, ultrasound, some fragments will be there. Now, some patients will
But are they significant?
Sir,
I mean, they are looking at the size of
sir,
the dusting.
ultimately 3 महीने के बाद 3 months afterwards, you see any 5 mm stone or 7 mm by chance, be unhappy, sir. This is the part we have to openly discuss. या relook करके wash करो या lot of time spend करो, because ultimate aim is not to compete
अभी ना
with
अपन थोड़ा
ESWL.
पावर बढ़ा सकते
Compete
हैं
with
because
PCL.
I am नहीं वापस रुको
This is ESWL.
don't.
Extra class ESWL this is. We have to compete with PCNL.
No,
This is
see,
what
RIRS, we are the fragmenters. Ultimately, the patient will have to excrete all the fragments and the dust. Pelvic calyceal system is not very conducive for you have acute acute
Correct,
lower calyx. Then some fragments go and sit in
Correct,
there.
correct. That's why
So then
better to do it under
post-operatively,
ventilation.
maybe
Not
in lower
post-operatively.
calyx.
Not
Are you all not comfortable? Tell me.
very correct.
Yeah. So post-operatively, usually we ask them to sleep on the other side so that that lower calyx is a little less dependent. Maybe all these small things would help. But as Chandramohan said, you might find a small fragment and patient needs to be
See,
counseled
there are
more.
nearly 1 lakh, 2 lakh, 10 lakhs fragments here. 10 lakhs.
Now, if I may comment here, I have Dr. Khadke with me. So, I had attended one conference in AUA where Margaret Pearl, who is one of the top urologists there, said that if you do a CT scan post PCNL, there is almost a 40% residual fragment
Yes.
incidence in PCNL. And what
Correct.
we are talking is that PCNL, there will be no fragments at all. Now, that's not
No,
true.
the
At
same.
their center, they have a protocol of doing a CT scan on the 3rd day because the insurance company requires it. And if the insurance company finds a fragment more than 3 millimeter, they don't pay the hospital.
My God.
So that is
And
the
I
protocol
think,
there.
They were talking about 43% residual stone rates with CT.
No.
See there. See what? See, small amount of water lapse. See, you missed. This will happen more at the end. Water, dust, this happens in ureter.
Jackie sir, I think the Indian scenario, when we say we have 100%, we confirm only on the fluoro. It is our perception.
Fluoro. And then X-ray will
No,
still
no. Sir,
show.
fluoro is of no use, sir.
No use actually.
Fluoro is of no. If you see fluoro, stone might have disappeared.
Once the fragments are there, they are not so dense. They will not be seen even if they are together.
I think Maggie has Maggie Pearl has even mentioned
Even
written a
at-
lovely article on is ureteroscopy as good as what we think. So even for flexible ureteroscopy, she has said that the residual fragment rate is very, very high because they have done CT scans of all the patients to see, and she has published this article. So I think that is how they evaluate. They do CT.
Dr. Nanjappa, hi.
Yeah.
Good afternoon, Aditya Sharma here.
Hi, Aditya.
What protocol I follow is I usually do a CT in all cases before first surgery and before the stent removal. So
Before the
even
stent removal.
before all cases, we do a screening CT, and if any residue is there, if patient pays, that's okay. We charge for that. If patient doesn't pay, we do it in the cost of stent removal only under anesthesia, of course.
There are two things to this. Very good, Aditya. You're doing a very good thing. I mean, you're trying to maintain, but
it is a
one
private
is the
practice,
cost
it is
and one is
practically impossible.
impossible because
Private
of the
practice,
cost
it is impossible.
and
Even
radiation.
in my own
There are
setup,
two
I am
things.
not able to do it.
Yes, we do sonography with X-ray.
Yes.
We do both sono and X-ray, and that's how we can manage. We cannot do a CT unless
cannot
there
do.
is a. We cannot do a CT.
And
So
it
in our
Yeah.
private practice,
Aditya,
cannot
Jackie again here. See,
Yeah.
whenever you're doing a test, there has to be a purpose to the test. So suppose you do CT and you find 3 mm, 4 mm fragments. Does it change your treatment?
Correct.
Are you
So
not,
what is
are you going to
significant?
take out
What
a
is
stent and wait
significant
and
after a
watch
CT?
or not? That's important. Why are you going to do a test just for the sake of doing a test?
No,
You are
sir.
not Margaret Pearl.
It's it's not for the sake, sir. What the purpose is, we share what is there before the stent removal with the patient. If there is only 2 or 3 millimeter fragment, I tell the patient, see, these are insignificant. But
Ultrasound
still in
will
the
do it.
mind of patient,
Yes.
if they are
Yeah, ultrasound
significant,
will do. Ultrasound
you will
will
have to
do.
get rid
You
of
want
them.
that
Many
popcorning?
patients don't agree to it.
Ultrasound.
No, but what
Hi,
again
Dr.
the,
Ranyappa.
Yes.
Lalit Shah here. See,
Yes.
one of the
Sonology
very
is
important
dependent.
thing is that the residual stone is a pain in the neck for everyone. For the patient, doctor, everyone is there. Now, the whole thing is that there is no exact definition about what is a residual stone. All right. Previously, it was non-significant residual fragment less than 4 mm was considered as that. And we feel very happy that it is a no residual stone. But when you do a CT or when you do an ultrasound where 2-3 mm fragments are there and when they combine together,
They look
you will
bigger.
always find it there.
They look bigger
And
also.
I can tell you one thing, you do something, patient gets pain and he goes to the third person, there are more than 20 cases running for the residual stones in the court of law.
Yeah, I am.
So
clear.
one has to be very, very, very clear what exactly are you doing. And at the time of discharge, in the discharge ticket also you should mention. Like he said, it's fine. You need not do the CT scan you do, maybe you will get 100%. But at the time of discharge and discharge summary, you should do a sonography and an X-ray. And whatever is to be found there, that must be mentioned and then your plan of action, what you are suggesting. If it is a 4 mm stone, you can suggest that it will go on. Like that, that should be there. Otherwise, the cases will be running and will create a problem because they, for the mind of this patient, any report with this say that there are
You
residual
observe, sir,
fragments,
now.
it is a stone.
It's like ureteric stone, what he is doing now. You observe.
Sir, about the cost of the CT also, in like
You
all
observe
the
now.
hospitals where I have been there,
He's in the calyx.
I asked to create them a code for 1,000 rupees
See,
where
he
do
has
they
to-
do the
he
CT
has to
and
generate,
we don't get report, we don't get any films. We just go and see on the PECs and I show the same on my screen to the patient also. See, this is a 3 mm fragment.
Number of
It's
times it
insignificant.
touches.
If you want, I can give you anesthesia, remove stent and remove this also. Many times, surprisingly, we find 6-7 mm stones also, which will be missed. Many times they have been missed on ultrasound. That's how we evolved into this practice.
but the other way is also there, Dr. Aditya.
1 minute, 1 minute. Aditya, let me just put it to you. You are saying you are going to ask the radiologist to do CT scan at 1,000 rupees for screening CT scan.
In
you are
my
going to
hospital,
put-
it is.
When you are going to put a flexible bag, how much are you going to charge the patient, my friend?
No, I don't charge.
You don't charge.
I do it-
Flexible, access to
I do it-
Everything is free of cost.
I do it.
Anesthetist is your wife, a friend.
Patient,
Kamal karte ho.
patient pays for
OT, which OT will refuse to tell you I'll give you OT free
Sir,
of
patient
cost?
pays
Come
for
on,
the
be
anesthesia.
reasonable, my friend.
Sir, patient pays for the stent removal under anesthesia generally. And
Doctor-
if it is the insurance case, they
We'll
anyways.
concentrate here. This part is important.
Chandramohan,
Yes, sir.
This is Kandarp here.
Yes,
I
sir.
just a very interesting discussion going on, and Nanjappa is doing fantastic job
Great
now
job.
here. Now, I think coming to the discussion itself, and I agree with Aditya. Unfortunately, many of the in the audience do not agree with his view. But in my hospital, I have been following up all the post-operative patients with the CT scan before removing the DJ stent. We do double, I mean, during the surgery, if I've done a job like Dr. Nanjappa has done, fantastic this thing. In that case, I know that even if the DJ, I'm putting a DJ is going to stay for at least 10 days, not more than that, because DJ related complications are also more. Now, before taking out the DJ, just for, because we promised the patient that we are going to produce a complete clearance for you when I do RIRS. So
No,
I
sir,
will
no.
just
I don't
let me
agree with
let
this,
me
sir.
don't agree.
You should not promise. No,
Do
sir.
not
No, sir.
do
This
not
is not correct.
Chandramohan,
Chandramohan, let
you
him
have your
finish.
own opinion.
Yeah.
Keep your opinion with you. I'm just telling you that my opinion is this. Whether you agree or don't agree, that's a very different story because
No,
everybody
sir.
has.
I'm asking you, sir, stone-free rate, how can you do 100% to patient?
Let me finish, my dear friend. You keep your horses down at this moment. Uh, I am doing a CT scan. I just listen, my dear friend. I can listen what you are talking right now. I, during the RIRS, we have to produce a result what we produce with the PCNL. Okay. The second important thing is that when we do a procedure, we have to give a result to the patient, right?
80%.
No, sorry?
80% worldwide.
Okay, forget about the
Even PCNL 85%.
My statement to patient remains the same. Whatever you are telling is your opinion. My opinion is that I am going to produce a complete clearance for you. There may be a possibility of a residual stone when I do a procedure. Simple. Now, when I do a CT scan, I want to find out before taking out the DJ stent that whether there is a residual fragment or not. There is a big possibility that there will be some residual fragment. If the stone is very large, there will be many fragments like this. Then in that case, I explain the patient that we are going to have a stage procedure. But for a stone like what Dr. Nanjappa is doing at this moment, 1 centimeter, I can expect him to produce almost a complete clearance. There may be a 2 mm residual stone. That is not important. Now, Lalit Shah was telling us that for initially started with the 4 mm, which is a clinically significant residual volume. Then it came down to 3 mm. Now it has come down to 2 mm, right? I think at this point everybody agrees. So before taking out the stent, if you do a CT scan and if you make a liaison with the radiologist, which we have also done, we are getting that plain CT done for 1500 rupees. The only point is that radiologist gives a report, but he doesn't give the film. He gives a CD and the report so that we have a documentation. There may be a residual stone. If there are many residual stone, I will go in and do the DJ stent removal under general anesthesia so that I can produce a complete clearance. But if there is a 2 mm stone left in the kidney, I explain to the patient that is normally when we have a 2 mm stone, we don't go for a RIRS or PCNL or a ESWL for in a general condition. So similarly, this 2 mm stone will come out. This is how I explain to the patient. Now everybody can have a view that you cannot produce 100% clearance with any procedure, for that matter, even for PCNL also. But we have to, when we discuss with the patient, we have to produce a result which is equivalent to PCNL, if not more.
Thank
that is
you,
what is my
Kandarp
concern.
and Chandramohan, for your lovely discussion. I think we have finished our case
Sir,
in this beautiful discussion.
sir, very nicely demonstrated, sir. One of the excellent case.
So thank you so much.
Really very
for
well done.
Lovely discussion. You can see the powder over there. Everything is so
Excellent.
clear and so nice. We are in the lower calyx now. That's the lower calyx. That's the upper calyx.
Sir, can you suck
Okay.
it out by any chance?
There is a suction. Wait for a month or two, and you will get a new device which is coming in from Biorad only.
Biorad
And we are
only.
doing the study on that. So it will be attached to your scope, and with all this dust will come out, and that will be there. So I just put a stent and come out. Thank you, everybody.
Great.
Thank you so much.
Excellent job, sir.
Thank you.
Extraordinary job. Very nice. Sir.
And Jackie sir, about the cost dynamics, I share one thing. Like my 60-70% cases are insurance patient, 30 to 40% are
Aditya,
cash patient.
before that, it's possible in Apollo here. My own hospital, I will do free of cost 500 possible. But in the discussion, do you achieve anything to the patient and is it recommended in guidelines? No. Because CT is radiation. Worldwide, CT children, one case I presented in Copenhagen, I told that CT I have done post-op to show the results. Everybody has taken ride on me. For just showing the fragments, You do CT in a child.
Sir, 1 to
Are
2
you,
CT.
are you a, they have taken ride on me that it's inhuman.
They have to
to
stop.
do a
Chandramohan,
CT.
Sir, there is no
Chandramohan,
evidence that
Chandramohan.
1 to 2 CT.
Friends, friends,
Another thing,
friends.
Hello.
Yes.
Wait, the other theater is ready.
Okay.
We'll start that case and you can continue the discussion.
Sure, sure.
From the
नहीं,
same
okay.
point where you have
Really,
left it.
Scope लगेगा.
हाँ.
Yeah, good afternoon, everybody. Now, as you can see on the X-ray, there is a. Am I audible?
Can you a bit
Hello?
louder?
Can you hear me?
Yes, yes. Oh, Prashant.
Yeah. Hello.
Hello, Bhagwat, can you hear me?
Yes, yes.
Okay, okay. So now you can see the X-ray. Can you see the X-ray properly? There is a single stone in the pelvis. Okay.
So now, Gaurang, you are doing.
Can you hear me properly?
Yes, yes, we are able to hear you.
Okay. So as you can see, there is a single stone in the pelvis, and it's a bifid system. So we'll have to select the particular calyx for that, and we are going to do mini perk on that. Okay. Now there are 2 or 3 just small hints I want to give what we do. As you can see, the same way you have got a ureteric catheter, and on the ureteric catheter you have this plastic. So we put plastic over the ureteric catheter so that it remains sterile. So that is number 1. Number 2, we attach infant feeding tube to ureteric catheter, so we get an extra length. So the person who is injecting dye or saline,
Dr. Gaurang Shah, just hold on for a second.
Yeah.
Just for there is a change in moderation. I mean, Dr. Lalit Shah, Dr. Rajesh Soni, and Dr. Pramod Rai. They are please come onto the dais to moderate this session.
Lalit Bhai.
In fact, yeah.
yeah. Okay. So we attach this 7 or 8 French infant feeding tube, depending upon 5 French or 6 French of. They are just felicitating. Okay, so Dr. Lalit Shah, can I continue?
Yeah, please.
Okay, so
Thank
there
you.
are 3 things which I was telling you. Number 1 is that we keep the ureteric catheter plastic cover, and we put it on the ureter after putting inserting into the ureteric catheter, so that it remains sterile. Number 2, we attach 7 French or 8 French infant feeding tube, so we get an extra length. The third most important thing is always inject saline before injecting contrast, because what will happen sometime, you might have put your ureteric catheter too much inside and it may be piercing parenchyma, and there will be extra extravasation. So once we inject saline, and if there is no blood, just remove it. The returning fluid does not contain any blood, then we inject contrast. Okay, start contrast. Knife से देना. Yeah. So this is a 12th rib, and this is iliac crest.
Gaurang, you are not putting any surface marking type of thing, lines and all that?
No, nothing.
Okay. I'm just asking.
Yeah. So important thing is that your screen should be at the head level. Otherwise, it becomes very uncomfortable
to see the images. Okay, contrast. Can you make it left to right? This image, can you make it left to right? Yeah. Now we have got, as you can see, it is like a bifid partly. So either I can enter from this calyx or I can enter from this calyx. And it is coming about the 12th rib. These are my markings. Now there are three different techniques by which we can do it. One is, as you can see, by bull eye technique or 3-point technique, or you can rotate it to 30-degree. But we are trained to do on not on a CM, on image intensifier. So most of the time, see, now I am very near to the kidney surface because it is moving even with the UCC नहीं डालने का पानी डालो पानी डालो गाइड वायर दे
Not in the.
क्या हो गया little manipulation of the needle जरा पानी डालो नीचे से whenever you push more water saline inside the guide wire will go very easily. That is the principle. Whenever you want guide wire to go properly inside the ureter, now there are two different methods of dilating. One is by a force and second is by screwing method. It is always better to use a screwing method, like you rotate in one direction and then in second direction, clockwise, anti-clockwise. As you can see my fingers. And every time I keep on seeing that guide wire is moving properly because in 2 dimension, you may bend the guide wire and you may go outside the system. Yeah. इधर तक गया मालूम नहीं पड़ता है ना dilated system था वो now clockwise and anti-clockwise. This is the method. So with that, there is minimum trauma to the tissue. नहीं सीधा वो डायलेटर ले लेंगे ना. हाँ minimum. Yeah, we have reached up to the stone. थोड़ा पानी डालो नीचे. एक 20 cc syringe with अपना ये था ना 10 French infant feeding tube है. ग्रॉस पीस अच्छा ग्रॉस पीस दे दो. ये 10 French infant feeding tube सक्शन के लिए यूज करना पड़ेगा. इनका तो होगा. थोड़ा काटना पड़ेगा. तो स्टार्टिंग में हाँ अब आएगा.
Gaurang, I was seeing that you are doing the screwing movement
हाँ.
in both the directions.
Yeah, both the directions.
Most of the people I have seen is that they do only unidirectional.
No, then
so what is the advantage and disadvantage?
See, I'll show you. If you see here, if you keep on doing in one direction, like this gauze piece, it is sticking to you. But if
Okay.
you do like this, it will not get stuck. And it's a smooth movement. I'm just doing it like this. And I'm not exposing myself to X-ray quite a lot.
Okay.
This is the first thing I teach to my students, that they have to learn this. ये है ना, ठीक है. पानी डाल. है ना, काफी आउटसाइड है हम लोग. Can you give me that 20 cc syringe with आगे से कट कर दे बेटा. कट कर. इधर. Now this is a good device for giving a wash. Pani. And you can even aspirate a small clot. पानी लाओ बेटा. As you can see, the clot has come out. और एक बार दे दें. Now it is coming clear. Laser. जरा ये 5 मिनट सीएम को थोड़ा पीछे लेके जाएंगे भाई. आगे लेके आएंगे. ये लेजर.
Endo view, please.
ये व्यू दिखाओ उनको. आगे लेके आना. कितने पे 1.2 16.7 ना.
Endo view gone again.
एंडो व्यू जरा दिखाओ उनको. अब व्यू पे. हाँ रख देते हैं. You can see it. Endo view.
Yeah, wonderful. Very clear stone, very nicely seen.
Sir, in this case, sublisser is also here. Where stone is there nicely in calyx and sheath is around what size, sir? Sheath, if you don't mind. Sheath size.
It is 14.
14. Pneumatic lithotripter better, laser better. Where we are changing? Is there any change going on?
I will tell you one thing.
Please, sir.
In my nursing home, I don't have laser.
Okay.
And I use only litho class.
Okay.
And I'm telling you, it works wonder.
That is one opinion.
Yeah.
We will listen from sublisser also, sir. We are watching, sir. Very nice view is there.
When in mini PCNL, actually you don't need dusting at all, because the very purpose of mini PCNL is that you make up fragments and then the fragments you have option to remove those fragments. That is the whole difference between RIRS and mini PCNL, where in RIRS you are forced to dust the stone completely so that there is nothing remains, because you are depending on the nature to pass all that whatever your fragments you have made from urine. Whereas in mini PCNL, you have option, or in fact the purpose is that you are actually removing the stone from the sheet. So on the spot clearance is there. So having a dusting in mini PCNL actually is not necessary. You have to have energy in such a way that you make a fragment small enough to be evacuated from 15 French size. So for that, whichever is the best energy for making a fragment, so that way pneumatic is very good, because it will fragment the stone and those will come out. But as of today, now actually of late, we have started doing a shock pulse and triology in mini PCNL. So that actually is becoming far better.
Mini, that means 12 French.
Yeah. So you have 1.8 French probe of shock pulse and mini triology both.
Vision is good, sir.
Vision is excellent. The advantage, the problem is that with stars, the channel size is less.
Less, yeah.
And therefore, that will go in Wolf and Olympus mini PCNL.
Okay.
Whereas it will not go properly in stars. But we have started doing shock pulse and triology both through mini PCNL. The benefit is that it breaks the stone effectively, and with ultrasonic energy, it actually sucks.
Okay.
So effectively, if you see your fragmentation, now we are doing prospective study between shock pulse and triology. We have already published the difference or the shock pulse and a triology and TFL. We have already published that study. The operating
what
time
laser-
is significantly less. Significantly less if you compare shock pulse and laser energy. So whatever mode of fragmentation you keep, whether you keep 2.5 and 10 or whatever for the fragmentation mode, that will not be comparable to the shock pulse, because it will, at the same time, it will get sucked out.
Yes, sir.
So even if you have a suction, which is like a Shah sheath or suction anywhere in the on the sheath,
Sir.
you still have to withdraw it up to the point of suction, and the fragments will get sucked out. Now with shock pulse, what happens is that the suction is on the probe, and that itself actually sucks out. There are attachments of laser with suction. Same laser fiber, you put it in the cook and stars, they make it. Through that hollow fiber, probe, you put a laser fiber. So like this, once you fragment the stone or dust the stone, same time the fragments are sucked out.
Yeah.
But those are all still experimental stage.
And cost effectiveness is
Cost effective is not there, and still it occupies the thing, and therefore the sucking of fragments is not that effective like what you get in the shock pulse.
So pneumatic is first
Pneumatic
choice.
is first choice.
Second laser.
Second is laser. And in laser, actually, when we do mini perk, we keep setting very low frequency and very high energy.
Energy.
So energy, sometimes we keep pulse frequency only of 5, and
Okay.
you increase to 2.5.
So it
Because
becomes
what
like
you want
pneumatic.
is a dent.
Dent.
You want a dent, so that fragment is
Not
not
powder.
Not necessary. Otherwise, you are wasting time.
Yes, yes.
If you see our shock pulse with 1.5 centimeter average stone, actual effective laser time, if you calculate in triology, the machine calculates the time for which it was active. The time is variable between 6 to 7 minutes. That's it.
Sir, which laser you are using, sir?
And Dr. Gaurang,
Yeah.
while you are doing the stone breaking, we would be just taking a lecture
Okay.
here.
Yeah, better.
I invite Dr. Chandra Mohan to deliver his talk on how to start RIRS for the newcomers. Dr. Chandra Mohan needs no introduction. Everyone knows him. He's from Hyderabad, running his own Preeti Hospital, doing a lot of work in RIRS and pediatric laparoscopy.
बड़ा stone है. अगर वो लिथो क्लास यूज करते थे तो फटाफट.
Respected moderators and the seniors and my dear colleagues. First of all, I thank West Zone Urology Society and Kamlesh for giving me the opportunity to talk and do the surgery. How to start RIRS in private practice is a commonly asked question. I will try to cover which scope to buy, which laser to buy, which accessories to buy, how much it will cost, how will you learn, and how will you practice cost effectively. Quickly in 10 to 15 minutes of time. Slides may be more, but I will roll more practical points. Please do not consider that this is one topic where there are no conflicts of interest. Whatever the experience we have used all types of scopes, we discuss with seniors, and then we give conclusion. Doesn't mean that you have to buy the same thing. Coming to the important part which I mentioned here is scope. See, scope is the durability is important and it should be cost effective. Normal flexible scope fiber optic will cost 5 lakhs. No warranty. 2-3 companies are there in India, not many companies. Coral Starch and Olympus. Coral Starch is Flex X2. Olympus is P7. Coral Starch is more flexible, more durable, my opinion, and literature also. But vision is little less. Olympus P7 has vision good. It used to produce dots. Later on, they made Duraband technology. Now durability has increased. Both are more or less same cost. So if you want to buy either of these things, you have to buy to start fiber optic. Usually, if you are fortunate, you will get 100 cases. If you are unfortunate, you will get 10 cases. In the beginning period, if you buy this and lose this, particularly in government institutions and very poor surgeon without richness from the parents and in-laws, you will feel disheartened and you will go to PCNL. Over, conclusion. Second, digital scope you have, that is over. Digital scope is chip camera like our cell phone. In future, the cost may come down. One good 15,000 Oppo camera will produce extraordinary image. Same thing will happen to digital camera. Already digital camera is dominated now in the Indian market by the Biorad endovasive scope. Fusen has not come that much. Lithoview has not come that much. Their cost is approximately 80 to 90,000, 1 lakh. Their monitor you have to buy separate for that, 3.5 to 4 lakhs. But if you buy 5 to 10 scopes, they will give the monitor free. 5 scopes cost is equal to 1 fiber optic scope cost. The feeling of having 5 scopes with you is great. If you lose 70, 80,000 only, you will lose. If you lose fiber optic, it is 5 lakhs. That's why for all the beginning, fellowship programs, training programs, government institutions, fiber optic scope is better. What is the disadvantage? Disadvantage is ideally they are disposable, but that concept has gone now. They are reusable, disposable. Whatever the way you imagine. They are reusable, disposable, or time limited, disposable. Now time limit also they are removing. That will be the change in the future. Now coming to the real disadvantage is sterilization. As of now, Biorad says that you can dip the entire scope into the Sidex, Paracep, Steroid. I am using, many people like MPUH is also using. It is true. It is working. Many have already practiced, so it's proven. Those who wanted to take it like that. Fusen also there. Some more scopes are also coming. It's not only Biorad, but as of now, more commonly used Biorad. That's about scope. So no much discussion. You have to choose between 3 scopes: Flex X2, P7, Biorad. Otherwise, any other scope you can try. But these are all time test model. For this, how much cost you have to invest? 5 lakhs. Now coming to the laser. Laser, again, today you have seen clearly. Laser, which laser? This is a disposable co I have opened and seen nothing will be there except plastic. Nothing inside. One wire and plastic I have opened completely in and out. In future it may come for 10,000 also. If 10,000, if you get a scope, if your own relative operating, you will open like a disposable plate in the during the dinner lunch time like that. You will not reuse it. Definitely, even if you don't want to reuse it, you don't reuse it. Western culture will come. So these are all the different pictures. That is, by seeing this, nothing will happen. You have to buy one only. If you see too many, you cannot buy. Like going for shopping for 5 shops, then you will get confused. Now coming to the guide wires and all, I will go at the end. First, laser we will discuss. There are 2 types of laser. Every time Oliver Traxler sir is, because his experience, I am mentioning his name. He says that for stone, 35 watts is sufficient. 30 watts is sufficient. So if you want to buy for 30 watts, there are only 2 missions. One is TFL, another is Homium. Forget about company. Homium, they are giving 17 lakhs to 24 lakhs. 17 lakhs to 24. Thulium, they are giving 22 to 28, depending on the area, depending on the negotiation, whatever maybe. So on an average, you have to spend 24 lakhs, which is sufficient. Why you wanted to do enucleation in the beginning? No. In private practice, first 5 years, this talk is only for first 5 years people, not for seniors, because they know what to buy. After passing MCH, you want to start. You know RIRS how to do. Then buy Homium laser 30 watts or Thulium laser 30 watts. 60 watts Thulium fiber laser is for enucleation of the prostate, which is not necessary. TURP can do the job because TURP instruments are less than 10 lakhs. Bipolar. Monopolar is less than 5 lakhs, 6 lakhs. So very clearly it is 24 lakhs. Previous one is 5 lakhs. Total together 29 lakhs. You have to invest 30 lakhs. If you go for the loan, you have to pay 30,000. Don't try to get from the patient. You will get it after the practice is built up. In the beginning only, don't try to charge, I will charge this much laser, I will charge this much, I have taken loan. You cannot tell to patient all this. Whether you can take the loan for 30 lakhs or not. Otherwise, 2-3 people you can share. This is about the laser. That's all. Guide wires, accessories, all we need not go into the detail. One access sheath is equal to 7 to 8,000, which will come for 4 to 5 cases. You average cal. If you are doing a fresh case difficult, you use new one. If you are doing post-tented cases, you use the old one. All guide wire stents, you know, it's 100 rupees, guide wire is 700 rupees, so they are not very costly. Now, how to use? If you are in a place like this where district headquarter, if you don't have your own hospital, there is a problem with holmium laser. Whereas thulium fiber laser you can carry. There is needless to say that all private practice first 5 years will be roaming practice, unless you have a already built up hospital. For roaming practice, thulium fiber laser has advantage. Flexible scope carrying is also difficult. Better not to carry. If you carry, you have to be very careful. Preferable to have the hospital, all the tray to immerse everything. I have made a steel tray. I will show that. Steel tray, I have made one steel tray which is very useful, which is only 10,000. This is the steel tray I have made. For last 10 years, I have made three steel trays I have kept. So that you use Parasafe, it is for 24 hours. You use Sedex, it is for 25 days. Both will cost 25,000 per month. 25,000 rupees per month. Don't think that repeatedly I am telling rupees. That is what the talk has been given to me, how to set up. If you want to set up, first thing you have to buy it. Now coming to the doing logistics. First 1 year, if you do less than 1 centimeter to 1.5 centimeter post-stented, better. If you have already learnt your MCH very well, your RIRS, then no problem. If you have not seen RIRS, then don't do it. Go to conferences, go to surgeons who can show you in the theater 1 or 2 days. 2-3 surgeons you go and come back and then do it. What Kandaswamy sir and Kandar Parikh sir used to tell me, Kandaswamy sir, do post-tented RIRS once, go see all the cases and come out. That's all. For 10-15 cases, so that you understand what is the scope. Once you understand the scope, it is not difficult. I have seen fellows doing within 1 month RIRS. That means it is easily doable surgery. In fact, PCNL is more technically demanding. That's why a lot of people are buying and doing it. Next is you stent all the cases. Like yesterday, Arshavardhan telling that all the cases is stenting. Then convincing the patient becomes a factor, because you will have only weekly one case. If you say I will stent, then I will do RIRS, then I will remove the stent, he may go run away. Then explaining, like what we are discussing CT about the Aditya Sharma sir, you should lose something to gain something. If you are doing stenting, do it free of cost. If you are stent removal, free of cost. You take directly in the package RIRS, they will be happy. If you ask every time 10,000 to 20,000, then 50,000, patient may not be comfortable. Depending on the nursing home or place where we have all done like that. We did not have hospital, we have all done like that. You should compromise few bucks of money to give the best care to the patient. If any small residual stone stuck in the ureter, if you charge another 40,000 rupees, you will get very bad name. You have to remove under short GA, remove the stone, only medicines they will pay. This is a practical tip for private practitioners. Institutions I am not talking, it is totally different. How to set up RIRS in private practice means it's only for private practitioners. Now coming to the wear and tear. In holmium, the flexible scope, only thing is that very common points they say, don't use the laser fiber inside the scope. That is the commonest cause of damage. You keep an eye on that. Number 2, don't flex the scope beyond your limits. Don't scope beyond the limits. These two are commonest causes of this thing. First 1 or 2 cases, you be mentally prepared for 30 to 40 cases only. That's why I suggest buy 2. That's why the entire era is going towards disposable. They will give 5, monitor free, 5 lakhs you will get. Only problem is, it is slightly bigger size, 10 French. That means your normal ureter, 30% chance that you may not pass, 30%. Tell the patient, put the stent, don't charge the original money. Don't take the RIRS money at that time. If you take, they will find out the stone is not removed and you have cheated them. This is the loyal you have to be with the patient. Now coming to the incurring cost, if the scope goes, don't try to get from the patient, it is your bad luck. As the number increases, you will get. initial practice, you will be on the negative side. Laser mission, it is not like that. If you get down, you will have 4, 5 lakhs, 10 lakhs, it may go. Laser fiber usually broken by you only. Blast sheet, like we are discussing, blast sheets is a common problem with chromium. That's why we shifted to thulium fiber laser. This is truth. You have to clean the dust, you have to maintain properly. Your technician is very, very important. 200 micron fiber, laser fiber maintenance is very difficult. Initially, one person will horizontally come and hit, and laser fiber will break. 40,000 gone. So these are the incurring expenditures. How much they will come average? Take it for granted. The scope 30 cases if it goes, the laser fiber goes in 3 months and blast sheet goes in 6 months. On an average, 15 to 20,000 rupees you will lose. That means your original EMI of 30 lakhs, which is 30,000 or 40,000, depending on the duration of EMI, plus 15,000 rupees incurring expenditure, 45,000 is lost to you. Usually RIRS is done in India for 50 to 80,000 rupees. That means if you do properly one case, that incurring expenditure is over. You should not calculate profit in that. It's a turnover. After the first case, you should think that you are getting at least 5,000 rupees profit. But because it is essential to practice RIRS in private practice, you should learn and practice. This is what my talk is. If any doubts, we will take for 5 minutes. Otherwise, my talk is over.
Wonderful, Dr. Chandramohan. Very, very excellent and practical tips for the newcomers. Wonderful. If there are any questions, someone.
Yes, please. Yes, that is actually subject per se. It is not private practice setup. One thing is you should have absolute sterile environment in the theater. Side X, if you want to put properly 20 to 30 minutes you put. Don't hurriedly remove. Lot of people are saying that head part you should not dip. How can you do surgery? Head part is the one which is contaminated maximum. You touch with your hand, you touch the penis, you touch the glands, you touch the laser fiber. Head part without inserts. That's where if any company says that, sir, head part don't put in the side X, you don't buy that. You can't buy that. Complete immersion is essential. We are in the era of steroid, not in side X parasef. So that is first thing, sterility. Second thing, urine culture theory, very important, but practical also. Urine culture better to have at least in diabetic, elderly, renal failure, large stone, where you anticipate large amount of time. See, more than 1 hour doing RIRS is not ideal. Even now, I am not crossing 1 hour. 1 hour is reasonable and postpone. Second thing is while doing surgery, if the water, this is my favorite point, if the water outflow is not coming, don't do it. Do PCNL. If you want to be in a hurry, want to help the patient, do PCNL. It is very cost effective. So pentally, you should prepare the patient for large stone for PCNL also. One person after doing 5 cases has sent a Staghorn type of picture. Can I do RIRS for this case, sir? You should not ask that question. No, answer is no. How can you do after doing 5-10 cases, nearly 3 centimeter stone in RIRS? For anybody it is difficult. Then fever will come, intrarenal pressure will rise, duration of the surgery, urine culture positivity, diabetes, elderly, these are the risk factors for fever. We have to apply 100% of our mind for that. And detect early. Raised pulse rate, tenderness in the early postoperative period is indication. To contact nephrologist. I am telling you, nephrologists can make you a lot of difference in antibiogram and making, because they in and out will concentrate on urine culture. Urologists don't see complete urine examination, urine culture. They see and they follow. That helped us in recovering the patients.
Thank you, Dr. Chandra. For
4.5 months baby, sir. That is the world's smallest baby reported. 4 months baby, bilateral RIRS, presented with anuria in the ureters and kidney stones. One side we have done it because it went well, other side we have done it. 4 months.
wonderful.
Luckily, it came from the institute, government institute, because they know that I am doing RIRS. They have stented pediatric surgeon, great. They have sent after 15 days to me. Both ureters were very much dilated. And that patient stayed for 10 days with low grade fever. After that went home well. Now that boy is 2 years. We have put him on medicine, metabolic workup. Before he has taken food, the stones are formed. No, no, sir. 2 years now. 2 years, 3 months he is now. We are following him. He doesn't have stone. Thank you, sir.
Okay, thank you. Dr. Gorang, we are with you again. We are seeing everything.
Yeah, there is
Yeah.
a one stone fragment which is migrated into the lower. Can you see? In the lower calyx.
Yeah.
पानी बंद कर देना.
इसकी जरूरत नहीं है. हेलो.
Yes.
पानी पानी जाने.
Am I connected to the auditorium? Lalit bhai?
Yeah.
Okay, so are you with कौन है वहाँ पे कौन है? गौरांग भाई से कनेक्टेड हो आप या हमारे से कनेक्टेड है?
See, I have almost broken it down.
एक्चुअली दोनों थिएटर से कनेक्ट हुआ है.
ओके.
गौरंग शाह का इंडोविजन व्यू आ रहा है, वॉइस भी आ रहा है और कंदप का वॉइस आ रहा है.
ओके सर, तो मैं रेडी हूँ, आप जब भी बताइए हम आ जाएंगे आपके पास.
ओके. आई थिंक गौरंग इज जस्ट फिनिश.
Gorang has just finished. Gorang bhai, wonderful job that has been done.
Yeah, I think it is done. I have to just.
Yeah,
put
yeah.
down
Thank you very much.
few
Wonderful
techniques
job.
over. Okay, thank you.
Yes, Kanda bhai.
Okay, so Lalit bhai, first of all, thank you Kamlesh and Chhattisgarh Urology Association and West Zone for giving me opportunity to demonstrate this RIRS procedure and lovely